I think it's okay to start the introduction, or should we wait? Okay,
Yeah, go ahead. Go ahead.
let's get going here. So I'm very excited to introduce Professor Elaine Nsoesie. She's an assistant professor at the Boston University School of Public Health.
Yeah,
I'm
go ahead.
getting
Go ahead.
feedback from myself here. So I'm very um, and is also a BU Data Science faculty fellow as part of the BU Data Science initiative at the Hariri Institute for Computing, which is an interdisciplinary data science program. She was previously an assistant professor of global health at the Institute for Health Metrics and Evaluation at the University of Washington, and she received her PhD from Virginia Tech in genetics, bioinformatics, and computational biology. So let's give her a warm virtual welcome.
Thank you, Andrew. Let me go ahead and share my slides. Great. Hi, everyone. Thank you for the invitation to speak here today. So I'm going to talk to you about some of the work that I have been doing on addressing problems in global health using non-traditional data and machine learning. So I always like to start with a slide just to tell people where most of my work falls, which is in digital epidemiology. So if you think about epidemiology as a study of the patterns of disease, injury, and health, and drivers of these patterns in specific populations, then digital epidemiology is basically the same thing, but with a focus on using non-traditional data sources. So this is data from places like social media, remote sensing, and the idea is to see how these data sources can help us improve existing systems and not necessarily to replace them. There's some cases where we do have data coming from internet sources that are not available through the traditional sources, so it can provide us insights that are not in the traditional public health surveillance realm, but in most cases, we're trying to improve what already exists. So an example would be, let's say you have two kids who are sick, and then the parent is searching for information online about their illness that can tell us about symptoms reported in a particular region, and can give us, if you look at aggregated data, it could give us an overall picture of what might be happening in a particular region. So I've used data from several different sources. This is just an example of some of the data sources that I've been looking at. So you have crowdsourcing data from places like FluNearU and iwaspoisoned.com. So FluNearU is a influenza-like illness surveillance platform that you get to submit information about your symptoms. You can fill out a survey online or on your phone. I Was Poisoned, as you can imagine, is focused on foodborne illness surveillance. And it used to be a website. I'm not sure if they have an app now, but people could report experiences of foodborne illness. So if you've eaten at a restaurant and then you later had symptoms and you think that you got infected at a restaurant, you can write a review about it. As you can imagine, it's not always true because different foodborne diseases would have different incubation periods, so you could get infected somewhere else and then blame it on another place. So the focus is usually on the volume of reports. So if we go from having 0 reports implicating one restaurant to having 60 reports in a day, then that's an indication that there's probably something happening in that restaurant. I've used a lot of such data as well, data from Baidu to look at influenza in China. We've looked at Google searches for several different purposes, from influenza-like illnesses to chronic diseases as well. So what are people searching for, and can that give us insight into what's happening in different communities globally? UpToDate data is another platform that we've used, and this is a clinician support website. So it's very useful if you compare it to the public-facing websites where people might be searching for influenza-related terms because maybe there's a news story about someone who's died from influenza. Then you'll see a spike in the data. But when you look at data from UpToDate, you would not see similar spikes because it's usually clinicians looking for specific information. We've used data from social media, especially Twitter and Instagram. Instagram, we looked at food choices in Kenya, where the idea was that as African countries become more urbanized, so Africa is currently the continent with the fastest urbanization rate. As more places become more urbanized, you also see more people changing the way they think about food and what kinds of food they consume. And so we wanted to look at Instagram to see what were people posting in terms of foods, and how has that changed from what you would have seen maybe in Kenya 10 years ago. We've used Twitter for lots of different purposes. I'm going to give you one example in this talk. We've also used consumer product reviews from Yelp and Amazon. So Yelp is more restaurant reviews. So when someone eats at a restaurant and write a review about it, we've mined that information to look at foodborne illness in communities, where the idea was to work with local departments of health and provide them insights into what is happening in their communities. So New York City Department of Health, Chicago, and Las Vegas are three examples of places that have used this data to either do targeted restaurant inspections, so they use data from Yelp and Twitter for that, or to do outbreak investigations. So New York City Department of Health has been able to find outbreaks on Yelp that were not reported through their traditional systems. We've also built a tool for finding unsafe food products on Amazon, where we look at product reviews. So when someone buys a product and they write a review about it, we want to know if the product is mislabeled, which is very important, especially for people who can have allergic reactions to things. So if a product that people are allergic to is included in the food product, but it's not included in the label, that can have very severe effects on people's health. So we've looked at that, and we've also looked at unsafe food products as well, in the sense of making people sick. Remote sensing is one that I would talk a little bit about as well. And then there's obviously news reports from places like HealthMap, which is a global disease surveillance platform. So let's start with remote sensing. So we've looked at satellite images and obesity in the US, and I worked on this with IHME, who is at UNC currently. So our goals for this study were to quantify the association between obesity and the built environment. So how much do features of the built environment explain the variation in adult obesity prevalence in US cities? We know that there is inequality in the built environment. So when you look at what people have access to, different neighborhoods have access to different things, and this can influence people's health outcomes. So if you have a sidewalk, you might be more likely to go out and actually take a walk. If you don't have a sidewalk, you might feel unsafe working outside, so you might be less likely to walk in your neighborhood. So in this case, when I talk about neighborhood, I refer to a census tract. And census tracts usually have on average about 4,000 inhabitants, minimum about 1,200 to maximum of 8,000. And we focus on obesity specifically because it's a major global health problem. It's not just a problem in the US. Globally, we have about 600 million adults who are obese. The number might be higher. In the US, about 1/3 of adults are obese. In 2017, rankings included 46 of 50 states had an obesity rate of 25% or more. But obesity is also a very complex health issue, so it's not explained by a single factor. Genetics has been linked to obesity. Early life influences have been linked to obesity, where kids who were obese are more likely to be obese as adults. Unhealthy diets, lack of sleep, lack of exercise, environmental influences. And we focus on environmental influences in this study because environments can affect your health in so many ways, from what you have access to in terms of the built environment to whether you have access to grocery stores that have healthy food options. So our study motivation was that there are differences in how people measure the built environment. So there's been quite a few studies looking at the built environment and obesity prevalence, and sometimes you will see studies coming up with different conclusions because you're using different measures and measurement tools. And we wanted to see if there was a way where we could process images and come up with a single indicator for a neighborhood, and then use that as a way to compare across different neighborhoods and also across different cities. So we focus on 6 US cities: Memphis, Tennessee, Seattle, Bellevue, Tacoma. Those are 3 different cities in Washington, and then you have San Antonio and Los Angeles. So the numbers that you see in the brackets, those are rankings of how the states are ranked in terms of obesity prevalence. So Tennessee would be the 6th most obese state in the US, while Washington would be the 32nd. So we wanted to have states that had really high obesity prevalence, but also states that had low obesity prevalence to see if our methods would be consistent across. We obtained data on obesity prevalence from the 500 Cities Project, which I think is an amazing resource for anyone interested in looking at health in cities. And this is data that was obtained through the CDC Behavioral Risk Factor Surveillance System. And this is run annually, includes all 50 US states and the District of Columbia and US territories as well. And obesity is defined as body mass index greater than or equal to 30 kilograms per meter square. So one limitation to this is that it's self-reported. So people can report things that are inaccurate, but in this case, we're assuming that what we're getting is reliable enough for us to do the analysis that we wanted to do. So we had data, satellite images was all the data set. So we had approximately 150,000 recent satellite images that were obtained from Google Static Maps API. And this was at zoom level 8. So here's an example of what that looks like. So you could see trees, you could see streets and houses mostly. And you could also see cars. We use a transfer learning framework because at the time, there was another study that had done something similar. This looked at predicting poverty using satellite images. So we basically use a similar method to what they use, but focused on obesity prevalence specifically. So we started with a convolutional neural network that had already been trained on ImageNet database, differentiate between 1,000 object categories. We dropped the last layer of the network, so it wasn't just focused on 1,000 categories anymore. And we basically extracted the features that were on the layer before that, which was 4,000 features. And the next step was, how do we make sense of those 4,000 features? So if you look at that visually, what we did was you have a lot of images from ImageNet. You've trained a CNN, and then we have a model, and now we want to basically retrain that using the images that we have of the neighborhoods in the US, which results in a transfer of knowledge where we get a feature map, and then we use that in our predictive model. Because we have so many features, we needed something that would allow us to only choose the ones that were most significant. And one limitation question that always comes up is that we cannot match these features one-to-one to features in the built environment. We've done a bit more work after the study to see what we're actually capturing. But at the time, there was no way for us to match that one-to-one. So we use ElasticNet. We use ElasticNet in different ways. So we have 5-fold cross-validation. We also had a separate training and testing set. And then we also had principal components regression analysis and compared our results across this. And in every single case, we had correlations between our estimates and our true data of about 65% or more. These we considered very high because we weren't really expecting that. And it was also one reason why we kept trying different methods to see if we actually get correlations that were lower. And we looked at, if you look at across the different locations, if you plot that, you have obesity prevalence here on the x-axis, model estimated obesity prevalence on the y-axis, and R-squared is about 75%. So one of the reasons why we were concerned about it being as high as it was we didn't really have something to compare to. And so when we had this paper on the review, one of the comments that came back from the reviewers was that the correlations were significantly high, but there was nothing that was in comparison to. There's been several studies looking at the built environment and obesity prevalence, but none of them had taken a comprehensive approach where you try to capture everything that you can see and see how that relates to obesity prevalence. So if you look at this visually, on one side we have San Antonio, true estimates from the CDC, and this goes from 18.9 to about 45.3%. And then on the other side, you have our estimates, so based on the cross-validation model. And you can see how similar they are in a lot of places, but also you have some underestimation in a few places. So for places where we had under or overestimation, you would, if you looked at the images, you either had the model being able to estimate that obesity prevalence would be lower or higher. So if, for example, if a place did not have a lot of greenery, which we later found was a very significant factor, the model would say that the obesity prevalence would be higher in that place. But some of those neighborhoods were high income neighborhoods. So even though people might not have space to go out and exercise, or might not have the kind of features that encourage them to walk or exercise around their neighborhoods, they have access to gyms and other recreational facilities that allows them to still exercise, and they can also afford healthy food options. This is Los Angeles, California. Again, you see very, very similar trends between the true and our model estimates. And this was consistent across all 6 cities that we looked at. In this case, just showing you images of, on the lower panel is where you have high obesity prevalence, and the upper panels where you have low obesity prevalence. So this is what most of the images looks like. Again, the same thing. On one side, you have higher obesity prevalence, and the other side, you have lower obesity prevalence. So just the same thing for all the different cities. As I noted, some of the limitations, again, are that the data is self-reported, so there's always bias in that. It could be underestimation.
I think
The reason.
May I ask a quick question here, please?
Yes, please go ahead.
So, obesity might be linked to poverty detection or the wealth sort of a community. If I look at Los Angeles, I guess I wonder if, properties closer to the ocean or something, beach cities and so forth, property values are higher. And so do you see such correlations, and is there a need to sort of separate out the two factors, or if we just focused on trying to estimate property values, we would find good correlation? I just wanted to get your sense of how.
Yeah. So obesity is definitely linked to socioeconomic status. So if you mapped poverty, for example, and you mapped obesity, you will see very significant correlations between the two. So we did do analyses where we used the same model and tried to predict income, and it did okay, but it didn't do as well as when we predicted obesity. So our assumption is that there were additional things that we were capturing in the model that was not linked directly to income levels in those different communities.
Very good.
Does that answer the question?
Yes, thank you.
All right. Okay. So the next topic that I wanted to talk about was focus on social media data and miscarriages specifically. And this involved people at Boston University, but also NYU and Virginia Commonwealth University. So a miscarriage is defined as the spontaneous abortion of a viable fetus during the first 20 weeks of pregnancy. And the reason why I wanted to do this project was this is a topic that is not usually publicly discussed. And I wanted to see if people are actually having discussions about this on social media and what were the potential impact of these discussions happening. The reason why I actually included in this talk, it wasn't my original slide deck, was because a New York Times article that just came out this morning actually mentioned the work we did, and I thought it would be a good time to talk about it. So Michelle Obama wrote in her book Becoming about her experience with miscarriages and how lonely and painful and demoralizing it felt, and how she did not know that other people that had this experience, especially the women around her, because no one talks about it. And in fact, about 15 to 20% of known pregnancies end in a miscarriage. And in the US, that's about 1 million pregnancies, so between 750,000 to 1 million pregnancies every year. So you would think that's something that happens so often, is something that people would talk about, but most people don't talk about it. And so people who experience it don't really know that it's happened to other people. Most miscarriages are due to genetic problems that have nothing to do with behavioral choices. But in the data that we're looking at, there were several people who were blaming themselves for the experiences. So we obtained 291,000 Twitter postings on miscarriages and preterm births in English. This was 2 years of data, so January 2017 to December 2018. And then we also obtained data where someone said, I had a miscarriage or my miscarriage. So there's a personal disclosures of miscarriages from about 5,000 users. So our first goal was to see what are the major topics of discussions within this data. What are the times at which we have significant increases in discussions, and what are the reasons why we have those significant increases? And then we did a sentiment analysis, and we did not use machine learning for this. We actually manually read through the tweets and tried to classify sentiment based on what had been done in previous research. So the 8 topics of discussions that we found in this data was, one was celebrity. So you had celebrities talking about their experiences and people reacting to that. And when celebrities talked about their experiences, you also had people who would share their experiences as well. There was a lot of politics about it. A lot of people were confused about miscarriage and abortion, or people were angry because they had to pay for the medical bills after having an experience that was very saddening to them. You had healthcare discussions, so people talked about the experiences, how doctors reacted to them, how nurses reacted to them. In some cases, the experience was good, in other cases, it was bad. Either they thought that clinicians did not fully understand what they were going through, so their comments were not very sensitive. And then we had preterm birth stand out as a topic of its own. And in this particular case, it was people talking about how high the rates are in the US and how ridiculous that was. Michelle Obama was another topic that came out because she had just talked about her experience as well, and then people were reacting to that. Loss and anxiety was a topic. So people talked about how many times they've had a miscarriage, or if they just had one, what they felt like and what they were going through. And then there was also anxiety about getting pregnant again and how they might lose that baby. And then you have discussions about the flu vaccine and the potential impact of the flu vaccine on miscarriage. There had been a paper at that time that actually tried to link flu vaccines to the risk of miscarriage. And the same authors later on wrote another paper that said there was not a link between the flu vaccine and miscarriages. And then there was ectopic pregnancy as another topic of its own, because it really stood out, and the people that were talking about it were people who had the experience, and there wasn't a lot of confusion as there was with miscarriage in general. So when we looked at events that were associated with increase in discussion, celebrity disclosures was one. So whenever a celebrity came out and said they had that experience, people would also share their own experiences as well. You had scientific studies also driving discussions, the flu vaccine study being one of them. And then you had discussions about things like on US premature births. The US released a premature births report, so people reacted to that. And then there was also the World Preemie Day, and people were also reacting to that. There were some incidents that happened at pharmacies where a woman had a miscarriage and went to get medication, and the pharmacist refused to give her medication to complete the miscarriage because they considered abortion. So that got a lot of reaction on Twitter. And then, of course, Michelle Obama's disclosure also. So we had 4 coders who manually coded the emotions for the personal disclosure tweets. So as I mentioned, we had tweets that said, I had a miscarriage or my miscarriage. And we had the major emotions that were coding were from another study that had looked at the kinds of emotions that people express when they went through this. So anger, annoyance, gratitude, grief, isolation, being neutral, or relief. In some cases, our coders agreed. In other cases, they did not really agree. So we ended up just presenting the tweets for which there were agreements between the coders. So grief was the most reported emotion in our data. About 50% of women said they experienced grief after their miscarriage. Some talked about this months after the experience, some even years after the experience. You had anger and annoyance as another. Anger sometimes was someone that had gone through this experience and then they had maybe a friend or a family member who was pregnant and then they felt angry because of that. And in other cases was people just not understanding. So they would see them pregnant and then later on saw that they weren't pregnant anymore and then would react to it in a way that was not very sensitive. And so people were annoyed by that. Isolation was another one. There were people who came to social media to seek community because they felt isolated with their experience and they wanted to see other people who've had similar experience and were talking about it. Relief was one. We mostly saw that with teenagers who either, or young adults who felt like they weren't ready to have a family and then they had a miscarriage, so they were grateful for that. Gratitude also for people who receive support either from family and friends or from clinicians. So what we learned from this study is that we need to talk a lot more about miscarriages because there seems to be a lot of mental health challenges with people who have gone through this. And part of the reason for that is because most of us don't understand what it is, and most of us don't understand how to react to it. Even clinicians don't understand how to react to it. And when we looked at medical literature around miscarriages, there wasn't a lot of discussion about mental health support. So they would talk about other ways in which individuals who have gone through this can get support, but mental health was not one of those that was included. And there's also a need to just reduce misinformation around it and improve understanding of the fact that for most people, this is a biological process and is not something that they have done to create this experience. And that is the wrong reference, but you can find the paper online if you're interested. So the last section is focusing more about the need to think about internet data and what it represents. So what is in your data? So I've done a lot of research thinking about representation. So there's a lot of data out there on public health topics on social media, Google, and other platforms, but who gets represented in these data sources? So one of the studies we did was look at postings from Yelp. So people writing about their experiences after eating at a restaurant. And what we found was that most of the people that were being captured in these data were individuals that were higher income and higher education. And so there's not a lot of representation of people from neighborhoods with lower income. And those are actually the neighborhoods that get affected the most, and they're the ones that don't get represented. In another study, we looked at reporting of physical activity, where we wanted to break this down by gender and look at differences across different states in the US. And what we found was that if you start looking, if you put everything together, you don't know who is being captured, you don't know the differences between different groups. But then when you start breaking them down, you see that there can be very significant differences, even between males and females for a lot of different states that we included in our data. A lot of the work that I've been doing recently has focused on sub-Saharan Africa. So thinking about how can we adopt the digital platforms of public health surveillance to create or collect more data, especially in situations where we don't have a lot of data. And what I'm learning is the importance of context. That different people in different countries think about health differently because of culture, and also share different types of information about health. So, for example, if you look at the US, you might get a lot of data about influenza like illness, or people might search specifically for influenza symptoms, or they might search for specific influenza treatments. But when you look at a country like Cameroon, for example, individuals, did you search for influenza symptoms? Did you search for treatments? But you don't get the same kinds of searches that you see in the US. But you see quite a lot of searches around natural or traditional remedies that people use at home to support themselves when they have a cold or other influenza-like illnesses. And they also search for things like, AIDS and HIV, malaria, TB as well, because these are diseases that they were very aware of. And so if you have a cough, they might immediately assume that maybe I have TB, and so they would search for that information. So we've been working around how do we develop more contextualized approaches for disease surveillance when we're looking at data from digital platforms. What are the kinds of information that we should be paying attention to, and how would that influence the kinds of models we build? So in this example, I have data from Cameroon specifically, and we're trying to model influenza-like illness. And what we found is that natural treatments were very significant in the models that we're developing, and so were searches for other infectious diseases that have high prevalence in this area. We're also doing this for chronic conditions as well, because the burden of non-communicable disease is increasing. As I mentioned, small urbanizations also associated with more increases in non-communicable diseases like diabetes, hypertension, with obesity being a major risk factor for that. Right now, if you look at the map of Africa, a lot of the highest prevalence is seen in South Africa and Northern African countries, but it's changing across the continent. So we looked at searches for behavioral risk factors. So if you look at the Northern African countries, so these are the top searches for terms that were most correlated with obesity prevalence in these countries. So Libya, Egypt, and Algeria have very similar searches. But then when you go to a place like South Africa, you start seeing differences in what people are searching for. And when I talk to colleagues in South Africa, they even had more specific searches than what I had. So they had, diet loss fads that had started and faded over time, and different things that people had been looking for weight loss in the specific country. So these analyses, when we did it for the entire continent. And I was thinking, how do we develop country-specific approaches that could be useful for educating people about diet, physical activity, and chronic diseases? Looking at Sub-Saharan Africa, there's a shortage of high-quality surveillance data, which kind of opens up new opportunities for us to actually use digital data sources to improve data in that context. There was also, as I mentioned, cultural influences in how people think about disease and health. Socioeconomic inequalities and representation is a major one, because in a lot of cases, most people will have access to these platforms or share information on these platforms. So people who are highly educated and come from higher income backgrounds. And then, of course, the ethical challenges around how do we use this data in a way that does not create more inequality in these countries, and also how do we use it in a way that people know that your data is being used and can actually consent to that process. So some of the solutions that we've proposed include digital literacy education, and I don't think this is specific to Sub-Saharan Africa. I think this is a global problem, as we've seen during this pandemic. It's very easy for us to believe what we see on the internet, and so there's definitely a need for more digital literacy education, and just basically educating us on how to find information and how to validate and verify information. Design of appropriate consent systems is another important one. Make sure that people's data is not misused. Methods that address a lack of demographic representation is another one that we think is very important. Seems like I went through that really fast. These are references for people who are interested in taking a look at that.
Yeah. Thanks, Helena.
Sure.
You want to take questions? Or
yes, definitely.
How do you handle validation of data, knowing that they are out there and is open? So how do you validate and you confirm that they're actually reliable?
That is a major challenge. So it depends on the problem that we're trying to solve. So some of the projects we've done around foodborne illness surveillance, for example, when we work with departments of health, they can actually go out and collect more information from these individuals. So they will contact people who've reported that they have a foodborne illness, and that individual can give more information. And through that, they can validate whether that was if there's actually an outbreak that's happening in that restaurant, or if nothing is happening in that restaurant. So that is sort of the validation process. For the search data, there's basically no way for us to validate that someone who's searching for the flu actually has the flu. But the idea is that if a community is interested in a particular topic, that is probably reflective of something that is happening in that community.
Thanks.
Sure.
Hi, can I ask a question? So for the sentiment analysis project, like you mentioned that when a celebrity shared about miscarriage, tweeted about miscarriage, a lot of people shared their own experiences. So I was wondering what percentage of these people shared the same sentiment as the celebrity?
What do you mean the same sentiment?
Like, let's say the celebrity said it was meaning it expressed anger. So would people who retweet that or like that or comment that tweet and share their own experience, would they also just talk about anger, or would they also talk about like other sentiment? I'm wondering from the perspective of how influential like such a celebrity would be in that kind of a network.
Yeah, that's a very good point. We didn't do any analysis where we looked specifically at the emotions that people express when they responded to celebrities' disclosure. We mainly just looked at whether they actually responded and what they shared. So if celebrity said, "I've had a miscarriage," someone would say, "Oh, I also had a miscarriage last year or 5 years ago." So people would share their experiences, or either support them and say, "Thank you for sharing this. It helps us talk about the topic more." But we didn't really analyze what the sentiments were.
Okay, and from your experience, would you think if more celebrities came out and shared their experience, like it would encourage more people to share their experiences?
I think it would, but I also think it's bigger than that. We can't just wait for celebrities to come and talk. But I think celebrities definitely have an impact when they share the experiences. People do share their experiences. But I think it's a conversation that should be happening at a community level where, women are talking to each other and saying, "I have had this experience," so that others feel like there's that support system. So when they go through it, they don't feel like they're isolated.
Thank you.
Sure.
So I have a question
Sure.
following about the obesity mapping project and following up things that you and Milne had talked about. So when you talk about trying to disentangle how the built environment influences obesity and influences people's behavior, so the machine learning method, like you said, can say, I predict that there's obesity here, and you can look at it and say, oh, maybe you can try to understand the models and it predicts obesity there because there's not green space. But then it's still difficult to get from that to, well, is it that people are more likely to exercise when there's green space, or is it that people who are wealthy live near, like to live near trees or something like that? And obviously this is a really difficult problem, but I was wondering if you have thoughts on if there's like a path towards more kind of causal explanations from these models.
Yeah, that's a very, very important question. I think for our particular case, the reason why we could draw the inferences that we made is because we're not the first ones to study this. So there's already been a lot of work that has been done in this space to link obesity to these different factors, but it's been done individually. And we were thinking more of what are ways in which we can do this more comprehensively. So instead of having one person go around and count trees in the neighborhood or count, whether there's how many sidewalks are in a city, we could actually try to use some of the AI techniques that are available to process images. And it doesn't have to be just satellite images. I have colleagues who have looked at street view images or other types of images in neighborhoods, and then build more of a comprehensive indicator of, if we put together all these factors, does it allow us to do this easier and faster? And I think this is could be very relevant for cities that are growing, especially in places like Asia or Africa, where you have really rapid urbanization. Can we monitor this over time? So not just a one-time period, but can we look at how this neighborhood is changing over time and how that could be linked to different health outcomes? And we don't have to just look at satellite images. We can look at other data sources as well, whether it's survey, and incorporate all the data sources to better explain what we're seeing.
Can I ask a question about, I guess, interventions in general? So when you, so I guess that sort of answers one way that the obesity study might have an impact, right? I mean, if you can establish that there's this kind of causal connection between green space and obesity, maybe controlling for some other factor. So in the case of like the miscarriage work, how do you see that being useful for an intervention? I mean, I guess traditional flu near year, the idea is, you can understand that an outbreak is happening and sort of start reacting before the standard signals get triggered.
Yeah, the miscarriage study, I think one of the things that we're hoping for is around mental health incorporation into the programs that have been designed for miscarriage management, so that people who are going through this can actually talk about the experiences and get the help that they need. Because some of the data points you see are not just previous experiences, where you have people who've had experiences, 3-5 years ago, who are still talking about it like it just happened recently. So I think if we can get to a point where this data can inform those processes, where clinicians can actually take this information and include it as a part of miscarriage management, then that would be a success.
I had a question about going back to the obesity prevention. Have you yourself, or are you aware of studies that look at some kind of dietary problems, some malnutrition, or things of that nature, and that go again from the same type of analysis from images and so forth to trying to figure this out?
I haven't done it personally, but I know there are people who are looking at agriculture, which could be a good indicator for malnutrition in sub-Saharan Africa, and try to see if they can use satellite images to inform that area. But I haven't personally done that work.
When you, in the obesity study case, did you, is it possible to interpret the 4,096 features? I think you mentioned that you had done some work looking at what you were detecting.
Yeah, we couldn't interpret the individual features, but when we went back and looked at what we were detecting, a lot of it was green spaces and streets.
Okay. Yeah, I was just wondering, because there's another paper by some of the same authors who did the nighttime lights paper, where there's an intermediate layer where they try to detect like trucks and I think like roof types of certain kinds. And the idea is you get something that's like a bit more interpretable because you forced it to go through these known types.
I agree that is very, very important and very useful. And when our study was published, we had those conversations over and over again with practitioners. How can we use this? How can we take this and do something with it? Yeah.
Hi, I have a comment. So have you, do you know about Moving to Opportunity project in US, where from 1994 to 1998, some low-income families in 5 or 6 US cities were given voucher to move to another neighborhood.
Mm-hmm.
And it was a randomized experiment in where like one group was not given a voucher and one group was given a voucher. And I was just like, this just came to my mind. Like there are like a lot of research which tries to look at the effect of moving to opportunity on like different outcomes, but and they couldn't find any effect on the health so far, but they haven't looked at the factors you just talked about, like effect of moving to a neighborhood in which has more space or which is greener, have a more walking area. So maybe that's a good idea.
Yeah,
Where establish causal effect.
that would be very interesting. I mean, there is a lot of work that's linking life expectancy to where we live, you know, the impact of place on our health. So if someone is moving from a low income neighborhood to another low income neighborhood, that might not really change what they have access to, and it might not improve their health outcomes. But if they move from, you know, a neighborhood that has less access to resources that they need to another one that has more access to the resources that they need, then that would probably have positive impacts on their health.
Thank you.
Sure.
Ask another question. Do you know if there's data available about what people eat, like at the census tract level? Do you think it would, I guess the idea would be, could you try to separate the effect of diet directly so that maybe you could better isolate exercise or something along those lines?
I don't know if the behavior risk factors survey captures food intake specifically. Yeah, I'm not exactly sure. There probably is. there probably is. So one other study we did looked at Twitter postings of diet and exercise, but for that study we looked at USDA data. So USDA has data on, you know, cheeseburger and how many calories are in a cheeseburger. And so we got some of that information, the caloric information, and then mapped it to the Twitter data to estimate calories, average calorie consumed for different counties based on what people reported on Twitter. So there's some of that data, but I don't know if it's available at the individual level or the community level. Probably might be.
Somebody asked in the chat if you could look at local food availability / deserts.
Yeah, that's definitely important, and there's been studies on that. So grocery stores and the quality of grocery stores around neighborhoods.
Very interesting work, and we will definitely, I mean, there may be other questions as well, but I just wanted to say that we will be more in touch going forward based on what you just presented. Thank you.
Thank you so much.
So I guess maybe if there are no more questions, we'll wrap up a few minutes early. Thank you for the great talk and for the long discussion afterwards. Really appreciate it.
Thank you. Thank you for inviting me. Next time I'll talk slowly. Bye.
Thank you.